and the impact of standardized best evidence-based care. Is going to present factors affecting the high percentage of cesarean sections. Peter, thank you for coming.
Thanks, Nikos. So I apologize, I have absolutely no Greek. None. So I'll speak hopefully slowly and relatively clearly, but I do apologize in advance. And this isn't my area of expertise other than I've been an obstetrician for 30 years. So I suppose I have some expertise, but I don't claim any academic expertise greater than your own. But I have worked in settings that have generally had lower cesarean section rates than Greece currently has. And I'm very grateful that the stage was set so well by the preceding speaker talking about factors that are influencing cesarean section rates here in Greece. And I'm really not going to talk about repeat cesarean sections and VBACs, but more on how we might reduce the rates of primary cesarean sections. So I have no conflicts of interest. So that is interesting. Okay, so the first thing to state is that the Greek economic crisis has been associated with an increased rate of cesarean sections in the country, as much as we understand, because Aris is going to show a slide which shows that for European-wide data, Greece is a gap on the map. So no national data are uploaded to the EU for benchmarking. But in one setting here in Athens, the rate of cesarean section has climbed over the interval from 2005 through to 2014, such that the crude risk ratio now is 27% higher than it was a decade before the end of this study period. That's a significant rise in cesarean section risk for women. It's associated with increasing age of the maternal population. So when I graduated from medical school in New Zealand in 1984, the average age of a first pregnancy was 24. When I left Vancouver in 2015 in Canada, the average age for a first pregnancy was 34. That's an uncontrolled biological experiment that has had an impact on our practice, and since I've done high-risk obstetrics for most of my career, had a positive impact on my busyness because it's just generated more work. I also heard somebody say the word Robson in the beginning of this, because that's about the only word I understood in the whole of the Greek that preceded my presentation. As you introduced the session, I mean, the Robson classification system is an important way of benchmarking how we are performing. I actually worked with Mike Robson in a town called High Wycombe in Buckinghamshire in England in the 90s. And he was a slave driver for the junior doctors, as I was then, and the midwives in the unit. Every day he would review every cesarean section and the conduct of every labor on the delivery suite to see how we could optimize our cesarean section rate. There is no perfect cesarean section rate. I don't think that anyone should state that there is. But there are ways of moderating rises in cesarean section rate, I believe. So the things I want to cover are induction, maternal request cesarean delivery, maternal age, BMI, fetal monitoring, confidence with operative vaginal delivery, litigation, public-private mix, and non-use of audit. So first of all, induction. So there have been two informative systematic reviews. So when I was a medical student, I was taught, and as an early trainee, I was taught that inductions were associated with an increased risk of caesarean section. However, that is if you compare women who go into spontaneous labor at 37 weeks and 6 days with women who are induced, presumably with an indication at 37 weeks and 6 days. Not all women who are pregnant and liable for delivery at some stage after, on or after 37 weeks and 6 days, if that makes sense. But if you do a randomized controlled trial of induction versus expectant care, you can anticipate something of a 20% reduction in caesarean section rates in the post-date trials, 18% reduction in caesarean sections, or for other indications. So that was a paper produced earlier in the decade, and there's now the latest Cochrane systematic review that Metin Gülmezoglu has led. And again, they find that amongst all comers at term or post-term, an 11% risk reduction in the rate of caesarean section for inductions at term. If you look at preterm inductions of labor, the odds ratio or the relative risk goes in the other direction. So preterm inductions are associated with an increased risk of caesarean section, but term induction isn't, as long as the term induction is correctly performed, and that means it's longer than 6 hours of oxytocin or 12 hours of a prostaglandin. It's actually a formal process of induction that may take days. So I'm going to cross that off our list, because in fact, inductions properly performed at term reduce the risk of caesarean section in randomized controlled trials, and they do so consistently, and there is no, I don't think there is any room for argument on that front anymore. What about maternal request caesarean delivery? I don't know if that's become an issue here in Greece. Women, too posh to push. The epidemic actually started when it became public in the UK that most of our female colleagues were electing to have elective caesarean sections in obstetrics and gynecology rather than go through labor to protect their pelvic floors and their sex lives. I've got 5 kids, all of whom have been delivered vaginally, so I am a proponent for choice. I think women should have reproductive choice, whether that's the mode of their delivery or whether they choose or to remain pregnant. It's all about choice. It's not a choice I've chosen to exercise, or I've been married twice. I'm currently in my second marriage and very happily so, but either of my wives chose. They chose to try labor. And in both North America and in Scandinavia, the impact of letting women who are informed and counseled about the risks of a maternal request caesarean section will increase your caesarean section rate by about 3%. I think that's a negligible impact on a problem that's running at your 40, 50, 60%, depending which Greek data you choose to use. So I'm not very concerned about maternal request caesarean delivery. I think women should be allowed to make that choice as long as they're adequately informed about the risks for that pregnancy and for subsequent pregnancies, and especially in terms of placenta accreta, increta, and percreta. Maternal age and BMI. From the same paper, if we have a look at caesarean section rates, there is increasing evidence that, in fact, increasing maternal age here is associated with an increased risk of, here's the cesarean section rate here. So is low birth weight, and just the fact that the rate has gone up over time. So as women become older, as they enter or complete their reproductive careers, that age is associated with an increased risk of cesarean section. And part of that probably comes from us. Your woman having her first pregnancy after the age of 40 has a more precious pregnancy in many of our minds. I don't believe those babies are more precious, but the opportunity to have a subsequent pregnancy is diminishing, and therefore people react with lower thresholds. I think it's part of who we are. We're caring people, and we worry more about a woman having her first pregnancy after the age of 40. I'd just like to say that our last born was born when my wife was in her 40s, and she delivered vaginally. The other issues associated with increasing cesarean risk are maternal age again, education. Women who are more poorly educated have a higher risk of having a cesarean section in this Greek study, in Crete. That's certainly not my experience. In my experience, it's women who are very affluent and very well educated who are pushing to have more cesarean sections. That teaching hospitals have lower rates, that being pre-hospitalized in pregnancy, presumably because you've got hypertension or the baby's growth restricted or some other issue, is going to drive up your cesarean risk. Subfertility and fertility treatment, again, it probably lowers the threshold for intervention. If growth restriction and prematurity increase the risk for cesarean delivery. And that was and these are the other socio-demographic associates, correlations. The other issue is BMI. So however you look at increasing BMI, it's associated with an increased risk of cesarean delivery. These pregnancies are more often complicated by hypertension, they're more often complicated by growth restriction or macrosomia, but you also end up with fat dystocia within the pelvis. So the baby there's just not as much room within the pelvis for the baby to fit through. What about fetal monitoring and confidence with operative vaginal delivery? So the admission cardiotocogram, how many units here, when the woman comes in labor, does the woman get an admission CTG or non-stress test, depending which phrase you use? Do most units do an admission non-stress test, CTG? Yeah. So if that's your institutional policy, that's going to increase the risk of that woman having a cesarean section by 20%. Compared with just if it's a low risk, spontaneous onset of labor, the woman should have intermittent auscultation directly right from the very beginning. What about confidence with operative vaginal delivery? I couldn't find any informative published data from Greece, and I did look for some time trying to find relevant data, though there are other data from Europe, North America and Australasia, and there's a general trend towards decreasing numbers of and training and an experience and confidence with operative vaginal deliveries, and also the willingness of women to undergo them. So if you're not willing to put on a pair of forceps or a vacuum device in second stage, and there is delay in second stage, or the fetus isn't happy, or the woman's becoming unwell because she's septic or has had a seizure or something, you've only got one alternative at that time, and that's a second stage cesarean section, which is always easy. Never any problems with the angles in the lower segment. That never extends, never any bother at all. So maintenance of confidence and competence around operative vaginal delivery is important to avoid that. In Canada, the process of training, the process of delivery suite management has become consultant-led. And it's somewhat litigious environment. Not as bad as the States, but somewhat litigious. And there are now trainees who have never done an unsupervised normal vaginal delivery, let alone an operative vaginal delivery, before they finish their training. So how confident are they going to be to do that sort of delivery, in their first consultant job? And the answer is not very, in my experience. There are 2 or 3 centres in Canada that have maintained forceps within the units, but most units are just using vacuums, and there are times when vacuums aren't as good as forceps to effect a vaginal delivery. Litigation is a problem. We came across this publication which is talking about the fact that litigation is becoming a real issue for practitioners in this environment, and talking about the necessity for no-fault compensation. So New Zealand, where I originally trained, has had no-fault compensation across the whole of medicine since the early 1970s. As a professional, you are liable for the quality of your care to the medical council, but not to the lawyers. And it has made the pattern and practice of obstetrics different in that environment compared with other environments in which I've practiced in the UK and in Canada. There are alternatives, and one I came across was this medical error reporting information system, again, which has come from Greece, and it shows that by investing in feedback loops and audit loops and surveillance systems for a relatively small price, you could moderate medico-legal risk, and that could have an effect in reducing accelerating rates of caesarean section if you felt safer as practitioners. I've never met an obstetrician yet who's been sued for doing a caesarean section, but I've known a number where there's been an adverse outcome for which they have probably not been at all responsible, where not doing a caesarean section has been an important point to discuss. Public-private mix is an issue in this setting. In Canada, it has the most highly socialized health system in the world after Cuba, but practitioners are paid fee-for-service. So women become billable commodities, and you are paid more for doing a caesarean section by the province than you are for conducting a vaginal delivery. That biases the situation towards more intervention, because we all like to take nice holidays. Personally, I want to take more holidays in Greece. This is my first time here. You might want to take more holidays in New Zealand. And to do that, we all need an income that compensates us for the stress of our profession. But where caesarean section and private insurance come into the mix, and that's a Greek euro, because you haven't defaulted to the drachma, unlike the UK, which is exiting this whole bloody process, that women who have private insurance have a 13% higher risk of having a caesarean section, and women who have go to private hospitals have a 40% higher rate of caesarean section across many jurisdictions. We know, but some of those women have self-selected so that they can have this caesarean section rather than private practice being responsible for the caesarean section. This is association, not cause and effect, but it's something for us to address. It certainly gives private practice a bad name. And what about the non-use of audit? Greece has avoided the European audit system for caesarean section rates. I don't know whether that's a good thing or a bad thing, but I would personally believe that unless you count your numbers and publish your numbers, you don't actually know to what you need to respond. So in a systematic review of audit and feedback using the Robson criteria in Brazil, Sweden, Chile, and 3 Italian studies, there was, in each of these studies, was a significant reduction in the rate of caesarean sections between before the Robson criteria were used and then afterwards. This one just states that they halted the rise in caesarean sections. In this Chilean study, it fell, but 12 months later was back up, whereas in this study in Italy, it went down to 11% and remained down 12 months later. So they were more effective at maintaining the use of the Robson's criteria. So these are the factors I wanted to discuss. Hopefully, I've crossed induction of labour off the list. I hope so. And the others are important. And how that would play and how to respond to those factors is an opportunity for us. Thank you.
Thank you very much, Peter, for your presentation. The discussion will be at the conclusion of the session.
Καθηγητής με ευτικής γυναικολογίας στο Πανεπιστήμιο